There's a lot of mistrust of the healthcare system among communities of color. So as a doctor, I knew I needed to participate in one of the vaccine trials. Now, the same vaccine I tested, which is highly effective across all demographics, will be available for free to all Californians. Many of us haven't been able to see our family members in person for over a year. This vaccine provides a light at the end of the tunnel. I'm Dr. David Tom Cook, and this is why I vaccinate.
Welcome, everyone. Thank you for being here. Tonight's panel discussion is on the race to vaccinate California's most vulnerable. My name is Art Hernandez. I'm a registered nurse at UC Davis Health, a family nurse practitioner at the Sacramento Native American Health Clinic, and a public health nurse. We are so glad you're able to join us tonight. This event is brought to you by CalEndow Live, the California Endowment's virtual public programming arm that offers health and racial equity programming for social change. It's open to all and free for the public good. This event is in partnership with UC Davis Health. The video we just watched is the vaccine story of one of our panelists tonight, Dr. David Tom Cook. In the video, he shares his message on why he chose to get vaccinated. As a reminder to participants, California Endowment sponsored gatherings cannot be used for political campaigning or lobbying activities. Over the next hour, you will hear from an esteemed panel of medical professionals deeply committed to advancing health and racial equity by ensuring that all Californians are protected from COVID-19. Please use the Q&A button at the bottom of your screen to submit your questions. Now, it is my pleasure to introduce our moderator, Dr. Tony Iton, Senior Vice President of Healthy Communities at the California Endowment and former health officer for the Alameda County Public Health Department. When Dr. Iton learned about this event, he was eager to find a way to participate. That's the type of public health leader California needs. Dr. Iton.
Thank you, Art, and thank you for your leadership in this and so many other things. It's my pleasure to be here tonight and to introduce and moderate this panel. We're going to be talking about some timely and fascinating things. We're going to try to take as many questions from our audience as we can, and we think that our panelists will be able to anticipate some of your questions in their remarks. It's my pleasure to introduce them, but I want to tell a quick story first. Many African Americans aren't aware of the history of vaccination in the United States, but it turns out that the originator of the concept of vaccination was an enslaved African by the name of Onesimus. In the early 1700s in Boston, he had been purchased, as was done in those days, by a man by the name of Cotton Mather in Boston. And at one point, Cotton Mather was in a conversation with Onesimus about smallpox, because smallpox had been ravaging the New England area for years, really for decades. And it was a scourge, causing 30% of the people infected to die. And Onesimus told Cotton Mather that when Cotton Mather asked him whether he'd been vaccinated, he said yes and no. And he described the process of variolation or inoculation, which was a traditional African practice, used in many other parts of the world as well. And Cotton Mather took this information, and variolation is just scratching the surface of one of the lesions, one of the blisters that occurs in smallpox, and taking some of the fluid out and rubbing it into a wound on the person who's being inoculated. And Cotton Mather disseminated this information throughout Boston. It was very controversial. However, it became relatively well known, so well known that George Washington in the War of Independence inoculated, in the same way that Onesimus had taught Cotton Mather, inoculated the entire US Continental Army. And many historians think that this may have been the reason that Washington's army was able to win the war. And of course, inoculation went on to become vaccination, and I won't get into the details of that, but ultimately that strategy eradicated smallpox from the world. So in many ways, the story of the success of COVID vaccination owes its origins to an enslaved African by the name of Onesimus. And African Americans should be proud of the fact that we brought this teaching, this knowledge, this wisdom to the United States. Well, I have the pleasure of introducing a very esteemed panel tonight to talk about some of these issues and to shed light on how they manifest today and hopefully answer many of your questions. I'm going to start with Dr. Cook. He is the chief of the Division of General Thoracic Surgery at UC Davis Health, a longtime advocate of health equity and inclusive medical research. Dr. Cook participated in the clinical trial for the Pfizer COVID-19 vaccine, which you're going to hear him talk a little bit about, and you saw some of that in the video that we just screened. Then we're also privileged to have Dr. Ackerman Barger, who's the Associate Dean and Associate Clinical Professor at the University of California, Davis, Betty and Irene Moore School of Nursing. She's a nationally recognized figure for pioneering teaching techniques that transcend cultural boundaries and that cross the urban-rural divide. And finally, we're very privileged to have Dr. Chiumbori Kwao, who's a third-year resident in the dual board family medicine and psychiatry program at UC, University of California, Davis. Dr. Chiumbori Kwao treats patients in numerous medical and mental health settings and is active in the UC Davis Resident Union and Black Resident Organization. She also serves as a medical consultant for the Civil Rights Clinic at the UC Davis School of Law. So I'd like to invite the panel to all turn on their cameras, and we're going to proceed to just tee up some questions for you to get you talking. And we're going to start with Dr. Ackerman Barger. Dr. Ackerman Barger, why are Black and other people of color getting vaccinated at lower rates? What is the larger connection to systemic drivers of health and racial inequalities?
Thank you, Dr. Aiton. I appreciate that question. If you wouldn't mind going ahead and bringing up the slides, I want to talk first about the concept of health equity. And in order to understand health equity, we need to break it down into a few points. I'm going to talk about the first points, and we're going to leave them aside, and we're going to focus on utility and quality. So we know that ability to pay is can be a barrier to health. If people don't have the ability to pay for their care, they're less likely to engage in health practices. And this is one of the reasons that the vaccine at this point is free and hopefully more accessible because people don't have to pay for it. The other thing is access. And of course, we use the term access in all sorts of ways, but in terms of this model, access means the ability of people to physically get to the place that they need to access care. And so what we see is there are clinics that are all over the place. We are trying to make this as physically accessible as possible. This also, in a general way, when we talk about health equity access, means the ability to find a provider who can give you the vaccine. And of course, there are, all kinds of people that are paid to give the vaccine, and then we have volunteer clinics. So utility is really crucial here because this is about if people have the ability to get the thing that they need, if they can pay for it or it's free and they can get there, will they choose to? And so utility is all about trust. Do people trust our healthcare system? And so there are many groups of people who historically have perhaps had reason to mistrust the healthcare system. For those of us from the African American community, we remember our history. We know from our elders, from the stories, from the lore, from the things that we've learned, that things have been, for lack of a better term, have been terrible in our past. We know that historically, people of color were experimented on when they were enslaved. A lot of people have the Tuskegee study in their mind. And I want to be clear, there are a lot of people that think that in the Tuskegee experiments that people were injected with syphilis, which is not the case. It was individuals that already had syphilis and were told that they were getting treated for it and were not getting treated for it. So if it's going through your mind or anybody's mind around you that, you know, there's a history of injecting people in this way from the Tuskegee trial, that's not true. But nevertheless, do people trust us as healthcare providers? And I think that it's on us now as healthcare providers to establish trust with. And you'll see that there are a lot of people in the healthcare community that are putting on Facebook or social media that they've gotten the injection. And this is to help reestablish that trust. Like, we get it. We will go first so that we can show you that this is safe, right? And then the other thing is the quality of care. So people are accessing their recent memories and their recent experiences to make decisions about whether they trust the healthcare system. And in that way, healthcare providers must up their game to ensure that we have the relationships with our patients, with our communities, so that when times like this come, that people trust that we're going to give them quality care, that we believe in the care that we give, we stand by our care, and we stand by it to the extent that we'll go first. We'll get the vaccine first. If you would go ahead and switch to the next slide. So there are healthcare disparities, and these disparities come from inequities that exist in our society. And so there are disparities right now in the way that vaccines are being distributed. You can hear this on the news. And so I want to talk a little bit about where those inequities come from. So one of them is lack of access. Are we getting the vaccines to the communities who are really in need of those vaccines? And of course, that distribution, depends on, do we have the vaccine? Are there people to give it? Is there a place to give it? And then, the next thing is, will people come? And so the next level of vaccine inequity is groups not trusting that this vaccine is safe and therefore not accessing it. And so all of this creates an inequity. And what I don't want to see is that there are specific demographics and groups of people who are not accessing, who are not getting the resources that they should be able to access if they want to in our society. And so I'm going to leave it there, but if you have any more questions about health equity, disparities, and equities, I'm happy to answer them.
Thank you, Dr. Ackerman-Barger. It's very, very helpful. And I'm sure questions will come up around this in the Q&A. We're going to turn to Dr. Cook now. Dr. Cook, tell us about your decision to participate in the Pfizer trial and help us understand the science behind the development of the COVID-19 vaccines. How do we know that they're safe and effective?
Well, thank you very much. And I really appreciate the California Endowment for inviting me and the opportunity to speak with this wonderful group of speakers. So I volunteered to be a participant in the Pfizer COVID vaccine trial. And the reason why I volunteered is to basically everything that Dr. Ackerman-Barger has said. I anticipated that there would be vaccine hesitancy and appropriate vaccine hesitancy based on historic interactions between Black and Brown communities and healthcare, as well as the current structural racism in healthcare. But I understood the impact of this pandemic on underserved communities and communities of color, and that impact has been disproportionate. So in order to walk the walk or talk the talk, I needed to walk the walk. So I wanted to volunteer for the Pfizer vaccine trial. The other reason why I wanted to volunteer is because it was the trial site was at UC Davis. And I knew and I know the individuals who are running that trial. I work with them every day. I take care of patients with them. And I understood their ethics, and I understood their commitment to our communities and their commitment to patient care. and I trusted them, and therefore I could trust the trial, and that's why I participated. Oftentimes, my patients say to me, I don't want to be a guinea pig when we discuss clinical trials. But the reality is that this Pfizer vaccine and the Moderna vaccine and the Johnson & Johnson vaccine are readily available, and individuals who take them aren't being the guinea pigs, because people like myself and the other individuals who volunteered for these trials already served as the guinea pigs, and the safety profiles were established, and therefore this is a safe and effective vaccine. Now, when we talk about the vaccines, in the United States, there are currently 3 vaccines that are available: the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson vaccine, or oftentimes the Janssen vaccine, because that's who they've partnered with. These vaccines are not FDA approved, Federal Food and Drug Administration approved, but they have undergone what's called emergency use authorization to be used in our society. So for emergency situations, certain drugs and devices can be used under an emergency use authorization. The wonderful things about these vaccines is that the data about their efficacy is publicly available. Just by going on to the FDA website, you can look at the raw data and results of these vaccines. Now, the 2 vaccines, Pfizer and Moderna, are what are called mRNA vaccines. So what happens is mRNA that encodes what's called the spike protein on the surface of the COVID-19 virus enters your body. That mRNA serves as a blueprint for printing out protein that mimics the spike protein, and that boosts your immune system to fight that spike protein. The third vaccine is called an adenovirus vaccine. And what that does, it takes a special virus that's been used in the past that encodes DNA from the COVID-19 coronavirus. And that DNA then goes on to print out that spike protein as well. The key aspect of all 3 of these viruses that are vaccines are available in the United States is that you cannot catch COVID-19 from any of these vaccines. Now, when we talk about efficacy, Pfizer and Moderna has a 95% efficacy, and the Johnson & Johnson vaccine has about around 75 plus efficacy. And what that means is that it's 95% effective or 75% effective from preventing you from having severe, moderate to severe COVID-19 symptoms as they pertain to infections. So you might look at the surface and say, well, does that mean the Johnson & Johnson vaccine is inferior to the Moderna or Pfizer vaccines? The answer is no, it is not inferior. In fact, if you look at the numbers of deaths from COVID-19, as well as hospitalizations due to COVID-19 in the Johnson & Johnson vaccine group, there were 0 deaths and only 2 hospitalizations. So it's 75% effective for preventing severe symptoms, but it was 100% effective for preventing death from COVID-19. So that is a key data point.
Thank you, Dr. Cook, and I'm sure we'll have some more questions along those lines as well if my past experience is any predictor of that. Dr. Chiambori Kwao, pleasure to have you. You've been doing work in the community, engaging folks to get vaccinated. What are people's fears, and how can the medical community best work to build trust with communities of color and have them continue, and those communities that are continuing to experience systemic inequalities and injustices?
Yes, thank you, Dr. Aitan. And the work that I've been doing, most of the concerns that I see from people stem from the fear that their particular set of clinical considerations hasn't been considered. Perhaps they have a recent shingles infection, or perhaps they are HIV positive, or perhaps they're pregnant, and they don't feel that maybe they will be a guinea pig for some of these vaccinations, and so feel that maybe they need to take a little bit more time. But then there's also issues with regard to support. Plenty of people that say, well, I don't have support to be able to be off work for a period of time to be sick with this, or I don't know if I'm going to be able to have be at an appointment this month and then again in another month. I'll wait for the Johnson and Johnson. And so where it is, there's people that may not necessarily feel as if they distrust the vaccine per se, but they would like improved conditions in which to get the vaccination. And so with that, I think that our charge as medical professionals is to educate ourselves on the potential issues that people may be having with regard to the vaccinations, particularly if they do feel as if they might be a guinea pig, or if they have had reactions to vaccinations or any sort of injections in the past. But it is also imperative upon us to actually try to break down those barriers, to offer that support, and to be consistent and frequent with our offerings. There's plenty of people that, go through, we do charts and we find people who haven't gotten their vaccinations yet. We see, give them a call, see what's going on, why they may or may not have gotten that vaccination. And for a number of people, they said, oh, I didn't know I could, or I didn't know where, XYZ. Plenty of people just need a lot of help and support. And so, it's whatever little that any person can do, providing not only the website information, but also the COVID-19 hotline information. I know that without a support system, which is not guaranteed for plenty of people, it's very hard to get to a website, and it's could be even difficult to get to a phone. But we're trying to be as resource forward as possible, continuing to direct people to the available resources and answering any and all questions that people may have, so that they feel safe and supported, and so that we can dispel the fears, whatever they might be, with regard to the vaccinations. And then, as I said, be a resource for people, and then also a source of support.
Thank you so much. So we've heard a little bit from each of our panelists. We're now going to open this up to audience questions and ask Art to field those questions. So over to you, Art.
Thanks, Dr. Eitan. Hi, everyone. A lot of great questions tonight came in from the audience. Really difficult to pick which one was to use. The first question, however, is how can non-digital natives, elder patients, and those with physical disabilities get their vaccines more readily? We'll toss that one to we'll give that to Dr. Eitan and the panel.
And so just in my experience, I can jump in and answer. And so at our clinic, we'll have just phone-based calls for folks that aren't necessarily on My Chart, which is the app that we use to communicate with our patients that, one, have insurance and are in our clinic, so that's just, there's a lot of people that aren't being contacted from that alone. But there are efforts to make calls out. And then the same places that were vaccine or that were COVID testing locations are now also applying to be COVID immunization delivery spots. And so we try to tell everyone is continue calling the hotline. Maybe we can share the hotline number in the chat here, and continue with everyone in your circle, especially the older folks that you care about. Because another thing that I'm seeing is it takes a village to get anybody actually to their COVID vaccination. And I know this because my own parents, I basically had to berate them from across the country to try and make sure that they were going to get into the car and they were going to get to the right place. And we needed family and friends to help us. And again, we need to engage our support system. And again, that isn't something that should be taken for granted because not everyone has a support system. in those cases, outreach efforts, physically being in person. We have a colleague of mine in family medicine department here at UC Davis. You may have seen a profile on her, Dr. M.K. Orsolak, just goes to people, offers the vaccination, immunization as they are available. And again, we're just going to have to be consistent, and this is a process that's going to be unfolding over months. So this is, this panel that we're having today, we're talking and it's just one moment in time, but we'll have the video to share with people. Everyone that's here will also be able to use their knowledge to spread out to others and to continue touching people in their networks, so that this time, this point, 6 months from now, we'll be able to see a little bit of a percolation of people finding answers and finding that place where they can get access. But it will be an everyday endeavor.
Thank you very much.
Let me just add to that, Art, that the state and 20 different philanthropic foundations have come together to pool resources in a fund to actually give grants to community-based organizations that have good relationships with, sometimes hard to reach populations or vulnerable populations, non-English speaking populations, folks that are homeless, et cetera, and seniors. And so there are grants that these organizations have. There are some 500 around the state to do active outreach to populations that may have a harder time tracking down the vaccine through their doctors or through the general, computer systems that people are being asked to use. And not only do these community-based organizations have the ability to track people down, but they also have the ability to use designated codes to create appointments for those populations as well.
Great.
So between the state and philanthropic organizations and local counties who are also funding community-based organizations to do vaccine outreach, there's an active effort to find people and help usher them to vaccine appointments as is necessary. So it's an all hands on deck effort that needs to happen in order to make this work well, particularly for those that are at the highest risk of getting sick, hospitalized, or dying from COVID-19.
Thank you, Dr. Iden. I'll address the next, I'll ask Dr. Ackerman-Barger the next question, and it's a really fantastic question. There are places across California, I would say the United States, that are a lot like portions of South Sacramento that don't have great access to the vaccine. And we know that some of these areas are also greatly impacted by infection. What's being done or can be done to address this inequity?
Yeah, so that certainly is one of the million-dollar questions. And I think that this creates a lot of anxiety for people because, we know that there are communities that are being impacted at a higher rate than other communities. And we expect our government, we expect our healthcare system to be able to provide as soon as possible. And yet there are so many barriers that come up. So I think that one, we have to be a little bit patient with the system. I mean, if you look at what's been happening in December and January, we're like, what is happening? What is happening? Why isn't there more, sites? How come I can't get this vaccine? But as we're seeing it, it's going faster and faster, right? One of the really important things is for us to have an understanding of what those areas of need are so that we can make sure that we go to those areas. And I think that this ties in, that there are areas of people and there are groups of people, particularly those that have access. And, the elderly are a great example of that. I mean, as we were having that conversation, I was reflecting on my own father, who is 84. He has difficulty seeing, he has difficulty hearing, definitely not in the digital age at all. What happens with those folks? And so I think we need to think about efforts where we are going to people, where people are not expected to come to us to get the vaccine, but we are going to different communities and going door to door to make sure that we are getting this important resource accessible to as many people and as many demographics as possible.
Thank you very much. And the one thing that comes to mind is the high density housing locations and the multi-families that live in under one roof and the impact that we can have there. And I know that there are ways of disaggregating that data using ArcGIS or some sort of demographic, looking at different populations and where they live. One thing that I'd like to ask Dr. Cook.
Art, can I just offer just one quick?
Of course, sure.
There are a couple of things that the state is doing to enhance outreach in an equitable way. One, the state has earmarked 40% of its supply of vaccines to those neighborhoods that have the highest level of socioeconomic risk. In other words, the neighborhoods that we're describing right now. There's also been a deep investment in mobile vaccination resources, which appear to be more effective at getting Black and Latino and other vulnerable populations vaccinated. And so there is a community advisory committee with the state that has been grappling on this issue of equity for a while. And that decision to earmark 40% of the vaccine for 20% of the population that are in these, so twice as much vaccine as there are populations that are at risk, was a bold move on the part of the state to really put equity first in its vaccination efforts.
That's great. I been a participant in GARE, which is government and racial equity working together. And I think to myself how important it is to vaccinate the vulnerable, especially when they're so many of the frontline workers across the state. This next question, I'll just leave it open, whoever wants to tackle it. And I want to make sure we get time for the question after that is, what are some of the ways that we can support individuals who do not have identification cards or are afraid of getting an ID card to participate in vaccination appointments? This is from a survivor who offered up her name, Winona Garcia, and we thank you, Winona, for your question. We have clients that are hesitant to create appointments because of this. What can medical providers do to help those with ID cards get vaccinated? I'm a nurse practitioner at the Native American Health Clinic, and I can tell you for sure we have vaccinations, and we don't, that whole ID thing, we barrel right through it and we give people vaccines. With the ID is not a limiting factor. We give vaccines based on people showing up to get the vaccine.
And I'll just reiterate that the organizations that are being funded to reach out to vulnerable populations, and when I say vulnerable, I mean that they're not naturally vulnerable. They've been made vulnerable by our policies. It's the threat or the absence of policy in the face of need that creates the vulnerability. So it's not the people, it's actually our society that makes them vulnerable. But the organizations that have been funded through both state funding and through philanthropic funding and county funding are the organizations that are in trusted relationships with many of these populations. IDs are not necessary, except that if you're using a 2-dose vaccine, you want to be able to make sure that you're giving the same dose to the same person, so that you have to track essentially to whom the vaccine has been given. So I think, my sense is you don't need a driver's license. You don't necessarily need, officially government sanctioned ID. They just need some way of knowing who you are, so that when you come back in 21 days or 28 days, they can give the vaccine to the same person that gave the first dose to.
Yeah, and I'll have to say that the Native American Health Clinic, it's the Janssen version of the vaccine that we were giving. So there was a single dose. So that does play into that. I have more questions coming in, and I appreciate the audience for these questions. Another question from Shantae Davies Balch. Please provide additional talking points on how to address patients who are shopping around or holding out for a specific vaccine versus just getting the vaccine that is available.
Yeah,
address that. Dr. Cook, perhaps?
I'm happy to take that. I think my advice would be to, as soon as you are able to get a dose of a vaccine, then go ahead and get that vaccine. As I mentioned before, there are 3 vaccines available that have been extremely vetted by our Food and Drug Administration, as by a special COVID-19 ad hoc panel to review the data from these companies. And that's a very diverse panel, and representatives from many stakeholders and for many demographic backgrounds. And again, all three of these vaccines are extremely effective, and they are especially effective from preventing death from COVID-19 and preventing hospital utilization, so requiring to be coming into the hospital from COVID-19. So as soon as you are able, get a vaccine, no matter which one of the three that it is.
A quick follow-up, Dr. Cook. Are there any particular medications like Tylenol or NSAIDs that decrease the effectiveness of the vaccines once you get the vaccine and then say you take the leave, or say Tylenol? Any?
I did see that question in the Q&A from the individual who asked that they took some NSAIDs after their vaccine, and they were worried that that might somehow diminish the effectiveness of that vaccine. And the answer is big picture, no. The over-the-counter medications such as Tylenol and Aleve or ibuprofen will not blunt the effectiveness of the vaccines. There are certain individuals, specifically individuals who are on a lot of immunosuppression medication, who may have received bone marrow transplantation, or I'm a cancer doctor, so something called CAR T therapy, where your immune system is extremely depressed. That might blunt the effectiveness of the vaccine, the vaccines require that your body's immune system attacks the material that the vaccine is using. But big picture, for the vast majority of our population, none of the medications that we are taking are going to blunt the effectiveness of the vaccines.
Right. So I want to ask this question, and we have a little bit of time, so I just want to make sure I ask all of you, like maybe, your 1 or 2 sentences. What will future generations say about our response to the COVID-19 pandemic? We can start with Dr. Eitan, if you'd like, or whomever.
Well, I mean, I think it's going to be mixed. I think it depends on what part of the country you're looking at and what part of the response you're looking at. I think overall, the United States of America did not do a good job responding to COVID-19. We were ill prepared. We dismantled many of the early warning systems. We had mixed messaging on masks and various other approaches. We were slow to roll out testing, both PCR and other rapid antigen tests. We were slow to roll out vaccines. The list really goes on and on. We've dismantled our public health infrastructure over the past 20 years in ways that are reaping real consequences now to the country. So I think it would be hard to say that we get an A. I think, though, that in places like California, as I mentioned earlier, this whole question of equity has been sort of front and center. Now, has California delivered on that promise? No. But California has done something I think that's a little bit unusual, and that is it's kept equity at the heart of the equation. And even counties, when they were trying to move within the tier system, the state constructed a formula that made sure that those communities in that county that were the poorest, that the whole county couldn't move until those communities also had an adequate level of testing, adequate level of vaccination. So California has, I think, set a good example for the country with respect to putting equity at the center of it. But in terms of achieving equity, that's a very different story. So overall, I would rate the US response as maybe a C minus. California, I might give a B minus.
Great. Dr. Zoll, you have any questions, any thoughts on it?
About how will be seen. And so I think about future generations very frequently, especially, what kind of world will my family members, my nephews and my niece, what kind of world will they inherit that I've left them? And I think about how for many of them, the majority of their lives, they don't see a crowd of people, that they wear masks and they understand masks, and they might even have a bit of social anxiety related to being around groups of people. And so I want them to be able to come back to, there's also the idea of, let's go back to things, and a lot of things you can't go back and change things, but I do want them to know a life that is somewhat safe from the invisible threat of environmental pestilence. But there are things that are related to our stewardship of this planet that make things like COVID-19 or COVID-20 or COVID-21 or, Ebola 2.0, there are different things that, in our global ecosystem that are making it so that these viruses are becoming better and more equipped at making humans their hosts. And so what I would want personally is us to have the foresight of thinking about what is this virus going to try to do, not just next year, but in 10 years and in 15 years, because these zoonotic infections are not stopping. This is not something that is ever going to go away. And so I want us to prepare as if we know that what our enemy is going to do. And that enemy, as I said, are these zoonotic infections that are having more opportunities to replicate and to jump around in different species because of a lot of deforestation, because of a lot of human-made interactions between viral particles. And so I want all of us to have a good head on our shoulders about what we're actually dealing with and how long we'll actually be dealing with it. And so I hope that ultimately, not just, we're not just vaccinating people in the US, but all over the country, all over the world, because it's mostly folks in the US, Britain, and Israel that are getting vaccinations at this time. We're actually very privileged as American citizens to even be offered vaccinations at this point in time. And so I believe it's an incredible blessing and it's an incredible gift. And I would like that to be extended as far as and wide as possible. And I'd also like us to protect ourselves from the future for whatever future zoonotic disease will impact us.
One plug, since I'm an Aggie in my soul, is One Health, or I think it's called One Health, which is a combination of the vet school and the med school kind of working together. I remember my days over at a small student physician-led clinic in Knights Landing. And so I think that's a big important aspect of this, is looking at this globally. And I appreciate what you're saying. Fantastic. Dr. Ackerman, Barbara, do you have any thoughts on how we might look back on this?
Yeah, I think that we will see this as a time when our country, our world changed significantly. People will be looking back. Remember the time when we used to get on the bus and just stick our hand on the pole and not think about it? Now all of us
breathe on each other.
It's hard to watch a movie. It's hard to watch TV and see people not masking up and not sanitizing their hands, right? And so I think that people are going to look back, remember when things were so much easier, right? So there's that piece of it. But my hope is that in terms of the future, that we will take this opportunity to learn, right? Even though we knew in a very abstract way, we were unprepared for this as a species, right? Like we haven't had to deal with anything like this in so very long that I think in many ways we got complacent about what it means to be prepared for whatever the unknown is, that we have forgotten sometimes what it means to look out for each other, to be community-based. Like this is getting the vaccine, wearing the masks is not about the individual. It is about us as a community and it's about us as a society. And so I'm hoping that this is the time when people say, remember when we forgot to do that? Let's make sure that we do that for the welfare of everybody. And, I really want to emphasize what my colleagues are saying is that this is very likely to be a new normal, right? The idea that we're not going to see another pandemic for 100 years, like it's been since the last time we saw a pandemic like that's highly unlikely. So my hope is that we expect it and we as a country are prepared for it, and that we're nimble, and that we learn the lessons that we need to learn to be able to respond. Like, we're so capable. The United States is an amazing country. We have the ability to meet pandemics like this. The technology that you were talking about earlier, Dr. Cook, about and Dr. Aiton, about the messenger RNA, that's not brand new technology. A lot of people think that that just came out in the last year or so, but it's been around for decades. We have been working on this technology over time. So if we get each other as individuals, as communities, as a healthcare system, as a government and a society, if we can pool ourselves together with this common goal, I think that we're capable of amazing things. I really, really am going to put my Pollyanna hat on and say that there is hope for us.
Well, I'm putting mine on as well. So there's that. Dr. Cook, I know that I'd like to hear from you. I have so many questions I'd like to ask you. I'd like to sit down and buy you a cup of coffee and talk about so much.
The coffee's on me.
What are your thoughts?
Yeah, so I tend to be a glass half full person. So let me focus a little bit on what Dr. Ackerman Barger alluded to in regards to these vaccines. So some people ask, well, how can these vaccines be safe if it took them only a year to develop them? And I would counter to say, well, this just goes to show what we can do as a society if we put our minds, collective effort, our communal will, money, talent, private sector, public sector, academia together and create something. And it's no different from in the 1960s, where we took computing power that's less than what's found in a smart device such as this, and put an individual on the moon and got them back off the moon and back to the United States and back to the world safely. And I think when we look back upon this moment, there's going to be a lot of issues that we're going to have to deal with in regards to our undervaluing of public health, and how what we need to really beef up our public health enterprise within the United States. But we will look back upon this and how we've developed these vaccines in a short period of time, and we're able to vaccinate large swaths of our society and have 95% efficacy. The flu vaccine is only 40 to 60% efficacy, and we have vaccines that are 75 plus in just under a year. And I'm excited to figure out, well, what's next? Can we eliminate malaria? Can we eliminate the flu? And that just goes to show, well, what we can do when we put our minds to it.
And I'm going to ask some yes, no questions. Will my body still have the ability to produce a defense if I artificially introduce a vaccine or a replacement?
The answer is yes. So you're not artificially introducing anything. As Dr. Aiton has pointed out, vaccines to some degree have been around since the days of slavery in our country. And vaccines are safe and effective in multiple different disease processes. What these vaccines do is prime your immune system to identify the foreign antigen or foreign material of COVID-19 to ideally prevent infection. But if you develop an infection, it prevents severe symptoms and prevents death. So one sort of extrapolative question is, if I have already been infected with COVID-19, should I bother to get a vaccine? The answer is yes. Now, do you need 2 doses of the Pfizer and Moderna? We don't know the answer to that, but the recommendation is to at least get 1 dose. And the reason is that if you've been infected with COVID-19, and we measure your antibody levels of your blood, so that's the material that your immune system uses to fight off the virus, your antibody levels might be lower than what it would have been if you had received a vaccine. And therefore, we have identified individuals who have had COVID-19 infection and been reinfected later on. And that might be related to low antibody levels. So the recommendation is that you do at least get 1 dose of the current vaccines if you have been infected with COVID-19 already.
So I'm going to pose this next question because of there are still folks who are skeptical. And so someone asked, I personally have family members who are skeptical of how fast the vaccines were produced. And we've talked about that the 50 years of research that's already behind this or more. And how can we help people, how can organizations in communities across California, the United States, help places like the California Endowment get the message out that these vaccines are vetted and helpful and save lives?
I will just add one thing is that, so there's a reason why other things took so long to be FDA approved, because they were rarer. There wasn't an all hands on deck trying. There were, I think it was over 40,000 people that were in phase 1 trials. The normal plan is about 5,000 people in phase 1 trials. So again, this has been the most rigorous medication rollout that this world has ever seen. And so this idea that it's been slapshod, that they're just putting all these things together, that is not true. You should be more upset that things have taken so much longer in the past because they have to sit on the shelf. People have to make sure they're going to make money on it. There's all these different things that really artificially elongate the FDA approval process. But because there was a need, we were able to have that same process, but then cut out a lot of the red tape, cut out a lot of the fat, and get to helping people. And so again, nobody here has been, and well, some of us here have been guinea pigs in Dr. Cook's case, but there's a lot of care has been taken to try and help people. And that is where we all are on this panel are coming at this from, with an abundance of care, with a desire to save lives, to help people, and to be able to allow people to get back to what really makes life important, which is this ability to gather, which is this ability to support each other and not be a threat to others. And so with community organizations, with family units, friend units, one thing is being yourself a beacon of light and truth and being able to speak clearly on what these things can and cannot do, because there are plenty of things that we don't know. As somebody asked in the chat, will we have to get boosters of these in the future? We don't quite know that at this moment. That might be perhaps something that we have to do, similar to the annual flu shot, but we don't know that quite yet. Studies are ongoing, but what continues to be ongoing is people's risk of hospitalization and severe injury and potentially death due to this vaccination. And so, again, being resource forward, being knowledge forward in yourself first, so that you can help the ones that you care and love for. Because it'll, most of the time, or at least I'll say in cases that I've seen, you say, you children are really worried and concerned about us. That's why we got this vaccine. We love you. We want you to stay around. I lost somebody in my family in 2020, and I remember the last time I hugged them. I want to be able to get back to hugging my family members and to seeing them in person. And I don't want to be a source of their pain. And this is not to guilt anybody into getting this vaccination, or this immunization. But there is a community element to illness. And we're seeing that way more now. And it's so very clear to us that it's a community that has its ills. It's a community that has its sickness. And so when we're not actually supporting the community, that's when we're having the hospitalizations and the mortality and morbidity. That's just the general harms caused by an illness. And so we want to reduce harm and in any way that we can across the board in medicine, not just related to COVID, but we want to reduce harm in so many different ways. And we try that by calling people into the community and then also ourselves reaching out and continuing on that, because you may not trust someone today. I mean, that's your right. But the way that we as medical professionals show you that we care is we continue to show up and we continue to be held accountable to you.
Thank you. Thank you very much. If your question was not answered, it'll be answered by the endowment or UC Davis Health staff. So we appreciate all of you, and thanks for the questions. The last question, Dr. Eitan, what is essential to take away from this conversation?
Well, first of all, I want to thank the panelists for their just excellent and thoughtful and measured commentary and insight. I think that you've helped this audience immeasurably understand some of the nuances around vaccination, but also feel more confident about vaccination as a strategy for themselves and their families. It's clear that African Americans, Latinos, and other vulnerable populations have been disproportionately impacted by COVID-19. The virus moved like a heat-seeking missile, taking down Black and brown bodies. And that's because of structural racism in our society. We also know that vaccination, the concept inoculation, came from, in America, came from an enslaved African-American man. This is a practice that Africans brought to this country. And it is, the history has been whitewashed. We don't talk about Onesimus. We don't talk about the wisdom of African people for millennia that protected ourselves from diseases and various other threats. So when we're thinking about these things, just do your own research, understand the history, understand the role that African Americans played in bringing vaccination to this country, and protect your families and yourselves and your communities by using these vaccines, which are highly efficacious, as Dr. Cook pointed out. They're unparalleled in their ability to protect people from getting sick, getting hospitalized, and dying from COVID-19. We need to protect ourselves and our communities. That's our responsibility. Again, I want to thank our panelists for this just wonderful conversation. And I want to thank the audience for the questions. And please spread good, clear, transparent information about COVID-19 whenever you have the opportunity. Thanks for participating.
We would like to thank the audience and program staff, faculty and physicians at both UC Davis Health and the California Endowment for their participation. For more information, you can visit COVID-19 vaccine myths versus facts at the UC Davis Health website. Please join us for the next event on April 12th. Activist D. Ray McKesson joins Cal Endow live in conversation about community organizing for racial equity. We leave you with this final video. Be sure to visit the Building Healthy Communities YouTube channel to see more videos that are available for public use. Thank you for watching and take care.
When my mom comes home from the hospital, she makes sure she's clean and sanitized before coming to see us. But we still can't be close. She always says, I knew the risk going in. And no matter what, I'm going to give you the care you deserve. Now with the vaccine, she can take care of herself so she can keep taking care of others. And when I get to roll up my sleeve, we can be close again.
I'm Janelle Gore, and this is why I vaccinate.